Hello, my name is Marlon Charles. I'm a family nurse practitioner student at Harding University. Today we're going to be doing the heart, peripheral vascular system, and the respiratory system. I'm going to step over here and wash my hands while my patient introduces herself.
Lisa Charles.
All right, Miss Charles. So the first thing we're always going to start with is inspection. So we're going to take a look at the patient, see that there's no visible edema, no ascites in the abdomen, no venous ulcers, and no varicose vein. Go ahead and have a seat for me, ma'am. Okay. We also see that there's no jugular vein distension. This at a 90-degree angle. We will reassess that again at a 45-degree angle. So we can go ahead and we're going to go ahead and start with palpation. So we're going to go from the top to bottom and check the temporal arteries here first. We want to check both sides. Okay. Check the carotids here. You always want to do one at a time, never both at the same time. Good. Go ahead and lay down for me, please. You always want to help your patient here. Okay. Okay. Now you want to check the 5 areas of the heart that we're going to auscultate. We're going to check. Go lay back for me. If we have any thrills, you'll be able to feel them. So first we find the sternal notch. That's the sternal angle. You go across to the second intercostal space on the right sternal border is where your aortic heart sound is. Go across to the left sternal border, second intercostal space, that's pulmonic. Down one to the third is Erb's point. Fourth is tricuspid. And the mitral, or the PMI apical pulse, is right underneath the mid-clavicular line. Good. I want to go ahead and check the brachial arteries here, which is in the antecubital space. I'm going to go ahead and check the radial. So we're checking the heart rate as well as we do. It should be between 60 and 100. We're also checking the rhythm. It should be regular, and it's a +2, which is expected fine. You want to go ahead and check capillary refill while you're here as well. It should be less than 3 seconds. That's good. Go ahead and lay back a little bit more for me. Okay. What we can also do here is check jugular vein distension. Go ahead and look that way for me, ma'am. Okay. And you can see here, there's no jugular vein distension. You can go ahead and do the hepatojugular reflux here. And mashing. Patient, keep looking that way, please. Mash on the liver, right upper quad. And you should see no jugular vein distension there. So you can continue. We can go ahead and check the aorta, which is slightly left of midline here. You can look normal now. Okay. And go down the aorta. Abdominal aorta bifurcates right above the umbilicus. We can go ahead and check the renal arteries, the iliacs here. We check both sides, of course. We can also be checking for any masses, and then the femoral. You don't want to use deep palpation if you do find any masses, especially in the abdominal aorta. When we go down, we can check the popliteal here behind the knee. Okay. And then you can check on top of the foot, the dorsalis pedis pulse, and the posterior tibial pulse. Good. That completes palpation. Percussion is not part of a cardiac exam, so we're going to go right into auscultation. Again, we want to start from the top to bottom. So we can first listen to the carotids here. We're going to have your patient look one way for me. Use the bell as stethoscope for here. Now we're listening for any bruits. First, you want to check both sides. Good. And there's no bruits noted. You also want to auscultate the abdominal aorta and the femorals and the iliacs as well. For time's sake, we're going to skip that for now and just listen to the heart sounds. You want to listen to the heart sounds, left lateral, sitting and leaning forward. For this purpose, we're just going to do it like this. You want to use both the diaphragm and the bell for the heart sounds. Again, the same points we just palpated: aortic, pulmonic, Erb's, tricuspid, and mitral. And of course, we go back and do it with the bell as well. So while we're auscultating, we're listening to the S1 and S2, which are the normal heart sounds, the lub dub. The S1 is caused by closure of the mitral and tricuspid valve, and the S2 is caused by the closure of the aortic and pulmonic valves. S3 is a heart sound heard in children and young adults. If you're over 40 and you hear that, that can indicate heart failure. And S4 is caused from a stiff, non-compliant left ventricle, and you don't want to ever hear that heart sound. Okay, so that completes auscultation. Next, we're going to go and move on to the lungs or the respiratory system. We start with inspection. We see that there's no nasal flaring, no cyanosis around the lips, no use of accessory muscles for breathing, no pursed lip breathing. And during this time, you could also be counting the patient's respirations, which should be between 12 and 20. The respiration should be even and unlabored. Okay. All right, so go ahead and set up for me. I'm sorry, I'm going to move your legs around this way. Alrighty, so the patient's AP diameter, anterior posterior diameter, should be less than the transverse diameter. You want to look at the chest here as well, make sure there's no lesions. Remember, the chest is not symmetrical. There's 2 lobes on the left and 3 on the right to accommodate the heart. That's why there's 2 on the left, but you can't compare both sides to one another. You also want to note any pectus carinatum or excavatum. That's a pigeon chest or funnel chest, and that completes inspection. Next, we're going to do palpation. So we're going to palpate the ribs and the thorax here. Want to feel for any masses, any tenderness. You want to check anteriorly, laterally, and posteriorly for this. I'll come around the back here. Of course, you're going to be feeling for crepitus as well, which is the Rice Krispie feeling. Any tenderness at all, anywhere, okay? So we go ahead and check tactile fremitus here. Posteriorly is best heard or felt between the second and third intercostal space on the back. With every you can use the palm of your hands or the ulnar aspect here. Every time you feel my touch, please say 99.
99. 99.
You want to make sure and avoid the scapula while you do this.
99. 99. 99.
Good. Okay. You can also check thoracic expansion here. So you want to, this one, use both. You put your thumbs underneath the patients around the 10th rib level and have them take a nice deep breath in and out. Good. And during this time, the provider's thumbs should be rising and falling symmetrically when the patient breathes in and out. Okay. Quickly back to tactile fremitus real quick. Decreased tactile fremitus can be found with infections, and increased can be found with masses or tumors. And that completes palpation. Next, we're going to move on to percussion. We're going to do this posteriorly. Okay. You should hear resonance in all areas of the lungs posteriorly. Any flat or dull sounds can be seen with pneumothorax or asthma, conditions such as those. That completes percussion. Now we're going to do auscultation or listen. You want to go from top to bottom. You want to start above. You want to use the diaphragm for this. You want to start above the clavicles. Have the patient take a nice deep breath in and out, please. Okay. So you hear vesicular lung sounds through most of the lungs. Okay. You hear bronchovesicular lung sounds over the major bronchi. Okay. And you hear bronchial sounds over the trachea. Okay. Good. Listen in the back as well. Of course, you want to avoid the scapula as well. Good. Lung sounds should be clear. You don't want to hear any crackles, wheezes, or rhonchi. Crackles can indicate pneumonia or pulmonary edema. Wheezes, of course, can be seen with asthma, and rhonchi can be seen with bronchitis. Okay. So the last technique we're going to do here is called I can actually stand in front here. Bronchophony, sorry. And you want to listen to the patient's lungs here and have her repeat 99 out loud.
99. 99. Or 99. 99. 99. 99.
And you should be able to hear this. And all the lung sound, you should be able to hear that. If it's louder in certain areas, that can indicate an underlying consolidation or condition. That's the last technique here. So, to wrap things up here, you want to let your patient know that there was no abnormal findings in this examination. You always want to educate your patient. So, to keep up your respiratory health, you want to don't start smoking if you don't. If you do smoke, you want to offer smoking cessation or help the patient quit with that. You also want to avoid secondhand smoke because that can be detrimental to your health and your lungs as well. In terms of cardiovascular health, you want to inform the patient to maintain a diet high in HDLs, which is the good cholesterols, low triglycerides, low saturated fats, and a total cholesterol of under 200 or 150. Also, low sodium is beneficial as well. The American Heart Association recommends less than 1,500 milligrams of sodium per day. And you want to teach your patient actually that the typical American diet consists of more than double that. So that increases the risk for bad things if you have a diet high in sodium. Any questions or concerns for me, Ms. Charles?
No.
Alrighty. And I will see you at your next annual physical.
Thank you.
Thank you. Have a good night. God bless.